Let's start. Good day and welcome to the University of Waterloo and to this Waterloo Smarter Health Seminar. I'm Shirley Fenton, Managing Director of the Waterloo Institute for Health Informatics Research. Thank you for joining us today for this seminar, which celebrates the University of Waterloo's 50th anniversary. I'd like to welcome as well our web viewers and Ontario Telehealth Network sites. Just to remind everyone, this seminar is being recorded and is being broadcast over the web. We ask that you hold your questions to the end of the seminar presentation so that we can get a real or virtual mic to you. A warm welcome to our guest speaker, Tom Closson. As many of you know, Tom has become part of our community, and we've been very grateful that he has done all the great work that he's done for Kitchener-Waterloo. Dominic Covey will introduce our speaker more fully in a few minutes. A special thank you to our seminar sponsors. As you see from the slide, St. Mary's General Hospital, Grand River Hospital, and the Greater Kitchener-Waterloo Chamber of Commerce have been very great in sponsoring this particular seminar. And to our seminar series sponsors, Borden Ladner Gervais, McKesson, Healthcare Information Management and Communications Canada, and Smart Systems for Health Agency. This is the fourth seminar of the Smarter Health Seminars, celebrating, as I said, the university's 50th anniversary. The anniversary theme is Why Not? And these seminars are dedicated to that theme and explore different why not questions related to health informatics ideas and innovations. I have a couple of announcements, very quick. We are holding a two-day health informatics boot camp in Waterloo. For those of you that are interested, there's more information on this flyer. It will be held June 14th and 15th. The class is filling up, so if you're interested in registering, please do so online as soon as possible. And our next seminar speaker is Dr. Jeffrey Fong, who is a professor at the University of Waterloo. He will be speaking on Why Not Evidence-Based Health Policies for Nations, the case of global tobacco control. Jeffrey is a principal investigator on a major research program involving a collaboration of over 60 researchers across 14 countries. And they're trying to conduct parallel national studies. It'll be a very exciting talk, so I hope you will all come back next month. So without any further ado, Dominic, will you please introduce our speaker?
Thank you, Shirley. Welcome to all of you. Very glad to have you here, either in person or on the web or through teleconference, video conference. Introducing Tom is a real pleasure. I said to him at the beginning, I have a hard time calling him a healthcare management consultant because of his background. Many people in management consulting have never had a background quite like his. I first heard about Tom, I guess, in the late 80s. I was asking him when he was at Sunnybrook, and immediately started hearing about him all the time. Perhaps most importantly, I heard about work he did in the early part of this century, where he brought together people under the Ontario Hospital Association to look at e-health, or health informatics, in Ontario, and what was happening in the hospitals related to technology, where they were going, what was needed, and came out with what I consider to be a landmark study that laid down a pathway which still is not in the process of being properly followed. His insight into that area, though, is remarkable. One thing that's relevant for those of you in the academic community is that study identified a need for health informatics professionals and identified the need to fund this to quite a substantial level. So it was very, very interesting work. He was president of the University Health Network and chief executive officer of the University Health Network for many years. Before that, he was in Victoria, British Columbia as CEO of the Capital Health Region. He's had Eastern experience, Western experience. And before that, was at Sunnybrook Hospital. Quite an incredible background. Most recently, he is, perhaps interest to all of you, he's on the InfoWay board, a very, very important part of the funding for e-health in the entire country. Tom's background is he earned his MBA in York University and graduated from the University of Toronto with a Bachelor's of Applied Science in Industrial Engineering. And I think you're aware that industrial engineering has gained a rebirth in the hospitals with quite a bit of work going on to improve processes, simulate and improve operating environments, for example, and so on. Among his awards, he had an engineering medal for the management of professional engineers from the Ontario and Hospital Leadership Award and the Canadian Healthcare Manager magazine. So I look forward to hearing, Tom, about why not create the ideal system with health informatics.
Great. Thank you. Thank you very much. Thank you, Dominic. Thank you, Shirley. And I'm really pleased to have a chance to talk to you about health informatics. I've always felt that health informatics was my first love when it comes to the healthcare system. I started my career actually at the Hospital for Sick Children in Toronto and was involved in informatics way back then. And in some ways, I look at where we are today and feel we haven't made quite the progress I had predicted way back then. In fact, I'll just mention this, so somebody might want to go dust off the Lalonde report, which was written in 1974, which says one of the major problems in health care today, 1974, is how our health records are scattered around clinics and doctors' offices and hospitals. So we need Lalonde well, back again, I guess, to see if we can push this along. I was asked to speak about health informatics, and I felt that probably the best way to come at this, particularly for me, given where I am situated in the healthcare system, which is really dealing primarily around health policy at the moment, is to talk about what are the views of others on what is the ideal healthcare system, and sort of sum it up in terms of what my own views are, and then show to you or demonstrate to you how it's pretty well impossible to achieve the ideal healthcare system without strong health informatics base, given if we really believe that those are the things that are going to make the system work well. So I'm sure just because you showed up today or you're listening in, that I'm probably preaching a bit to the converted, but I think it would be useful just to think of how pervasive the need for health informatics is if you want to have a highly functioning healthcare system. And the fact is that in Canada today, we're just starting to come to that realization. You know, as mentioned, I'm on the board of Canada Health Infoway. It's only been the last few years that the federal government has identified as a need. And if you look across the country, and I'm not going to do an interprovincial comparison in my talk today, but if you look across the country, there's pretty wide variation in the extent to which individual provinces have identified health informatics as a high priority. And I think you'll see over the next 5 to 10 years, some provinces will be able to move ahead much more quickly in terms of the effectiveness of their health systems, depending on whether they've seen it as a high priority. So I'm going to talk a bit about the issues and forces at work in terms of health care. I'll give you a couple of metrics and a few stories, and then some views, other people's views as well as my own, on how to improve the health care system and the key directions there. And then I was going to talk about how that links back to health informatics. So let me just subtly touch on health informatics as I go along, but really where I'm really going to focus on health informatics is towards the end of this talk. Now, in terms of healthcare issues, there's really 3 key issues that we have in healthcare. One is cost, the second is access, and the third is quality. And if you look at it from a cost perspective, I say here that we have 10 years of overspending. And what I mean by that, if you look at population growth and aging, and you look at inflation, and you add the two together, the impact of the two, we're actually spending on healthcare, and we have every year for the last 10 years at a higher rate than those two combined. Higher rate than those two combined. And drugs in particular has doubled their share of overall spending. We're spending about $148 billion a year now on health care. Drugs has increased their share from about 9% of the total to 18% of the total in the last 20 years. So that's the sector that's really expanded in terms of its costs, particularly. Inconsistent access, the reason wait times have been getting such attention across the country, both federally and provincially, is because all the polls say that's what the public cares about. They care about access. But it's not just wait times, as you know, in Kitchener-Waterloo, a lot of discussion about access to emergency departments. And it's not just the wait times that the federal government has identified as sort of the key areas. It's many other services, many other procedures that people want access to. And then on the quality side, the Baker Norton work that was done a couple of years ago, which picks up on work that was been done in Europe and in Australia and in New Zealand, shows that approximately anywhere up to 23,000 people are dying in our hospitals each year in Canada from preventable events. So these are events that, had we handled things differently, 23,000 people could potentially, fewer, would have died in our hospitals. So the kinds of things we're talking about here are infectious diseases, people going into hospitals getting diseases, infectious diseases or infections as a result of surgery. It's things like drug errors. It's things like procedure problems. It's even things like the assessment by nurses of patients and whether they're at risk of getting into a very dangerous situation. But 23,000 is a huge number. I know my old hospital, UHN, if you do the math, that's about 300 people a year dying unnecessarily, you could say. I'll come back to that, and I'll come back to each of these, I suppose, as I come back to talk about information. But these are the three issues that are our biggest issues in healthcare. And I'm going to talk a little about the forces at work, the political forces, financial, population, and delivery. Public pressure. The public is putting pressure on governments for better access, as I mentioned before, but there's also pressure starting to materialize for choice. This is the pressure related to, should we have a two-tier healthcare system? If I have the money, why can't I buy the service if I have to wait a long time? And of course, some of that's already happening. I live half of my life in British Columbia, and you may have heard British Columbia now has an emergency department, private emergency department that's been set up in Vancouver using doctors from outside the province so they get around the laws, and you can go in there and get emergency services and pay for it. You pay a certain amount of money for it. In Ontario, because the government doesn't have all the money in the world for cancer drugs, they're now not standing in the way of hospitals infusing drugs, cancer drugs into people, drugs that the government doesn't want to pay for at the moment, and allowing people to pay for their own drugs. So there are already these kinds of things happening. The question is how widespread it becomes, because the choice issue is becoming an issue on top of the access issue in terms of public pressure. Uncoordinated government leadership. We have an odd situation in this country where we have both a federal government and a provincial government that has an interest in health care. If you go to England, they only have one level of government. They have a population that's twice as big as ours, but only one level of government that deals with health care. Australia has two levels of government. But in our country, you feel the struggle all the time between the federal government and the provincial government, or whose responsibility is health care really, and who gets the credit for the kind of initiatives that are implemented. Election cycles, huge issue. Big turnover. Governments, as they change, because they change maximum 4 to 5 years, the focus on longer-term initiatives to make change to health care is pretty hard to achieve. You have to figure out what you can do. You start at the beginning of a term, do the bad stuff in the first 2 years, because as you get closer to the end, you certainly don't want to announce anything that's going to upset anyone. And the election cycles as well have some implications for the turnover in deputy ministers. You should go have a look at the deputy minister's boardroom in the Hepburn block and see how many different pictures there have been over the last 20 to 25 years. The same for, if you go to the minister's boardroom, you'll see the same thing. We've been actually very fortunate, I think, in the last few years. We've had a minister for almost 4 years, but that hasn't been the pattern over the last 10 to 20 years. So these election cycles, the turnover of people, these are forces that have a huge implication for continuity and risk-taking in terms of making change in the healthcare system. I want to talk a little bit about the financial forces. I said that I used the maybe inflammatory term of overspending in healthcare, because who knows what's the right amount to spend. But if you look at it as a percentage of real gross domestic product, this is another thing that's been increasing at quite a rapid rate. We were only spending 6.8% of our real gross domestic product in 1979, 8.9% in 97, and 10.3% in 2006, the most recent number. So it continues to rise. Now, having said that, just as any good person showing data, I've omitted 1992, I think it was, where it was 10%. So in fact, it went up to 10%, dropped back down to 8.9% as we all took money out of the system, and also the economy grew, and then now it's creeping back up. And I think one of the challenges for government, you'll hear all the time government saying, well, what we're concerned about is pretty soon it's going to be our whole provincial budget that's spent on health care. In fact, but it's not just the whole provincial budget being spent on health care. It's also what percentage of GDP should we be willing to accept. And I'm sure you would all know that we're not the highest. The United States is the highest, up around 15, 16, or whatever it is now, percent of their GDP. And there are a number of other countries that are a bit higher than we are. But it is growing faster than real GDP. And as I said, go back to 79, it's quite a significant difference in terms of percentage. There has been a real drive to increase cost effectiveness, a real concern that we aren't necessarily getting value for the money that we spend. And if we take something like the drugs that I mentioned before, an example that was given to me a couple of days ago is drugs for colorectal cancer. A number of years ago, you could spend $5,000 for a colorectal cancer drug that, on average, person who received the drug would live, let's say, 12 months. That would be the average. Now you can spend $200,000 on drugs for a person, and their life expectancy on average would be 20 months. So for the extra $195,000, you just bought 8 months. Now, from the government's perspective, and from society's perspective in general, is it really worth, $195,000 for an extra 8 months? From the person's perspective, it obviously is. And of course, if you told a person that even if you had 5% chance of living with this expenditure of that amount, they would, I'm sure, think that this was probably worth a chance of taking it to see if they could potentially live. But the focus is clearly on trying to get more effectiveness squeezed out of the dollars, given that the costs are rising. We have a lack of information on supply, demand, and capacity. We've now, in this province, started to develop regional service plans. But if you look at the regional service plans, you won't see a consistent format to what they actually include. And this would be true across the whole country. If you look at the regional service plans, the extent to which they really look at the demand for services, the various services, the supply of those services in terms of the various capacities and other ways of measuring the services, and looking at what the gap and what the real, whether we have the right balance of services. This is the kind of analysis that does require an awful lot of information, but we don't have that kind of information. Instead, we tend to put something in over here and put something in over there. It's like putting a bit of a thumb in a dike in terms of trying to actually address the very large systems problems that we might have. And they're quite dysfunctional compensation methods. I noticed when I was rereading this, maybe the word isn't dysfunctional, maybe it's inconsistent, which I guess is what makes it dysfunctional. We have some approaches to compensation that are volume-based. So, doctors being paid fee for service for the most part. Hospitals paid primarily on a global budget basis, although with a little bit around the edges being volume-based. Hospitals are starting to be funded more now on a volume basis. That's, this is something Senator Kirby certainly recommended. Come up with rates for volumes of service, and that's what's being done for the wait time strategy in Ontario. You give hospitals so many dollars for each additional procedure they do, so it's volume-based funding. At the same time, the kind of dialogue that's going on with doctors is moving them more towards alternative funding arrangements, which is more global funding. So you've got them sort of crossing each other. And in fact, if I look at most of the alternative funding mechanisms that have been established across this country, they don't really have much in the way of incentives. They don't have a good incentives to actually do work. They're more making sure that you get compensated, but at a reasonable level. So it's more of a competition thing, so that you don't go work somewhere else. But building in incentives to be productive, or maybe even better, incentives to produce high quality or get good outcomes. These are things that aren't there. And hospital funding as well. There's no hospital incentives to produce good quality. There's no hospital funding incentives to produce good outcomes. If there are incentives, it's to do more. Now, you might have heard Alan Hudson last week saying that he's going to change that with the wait time strategy, where he wants to build quality indicators in. So not only will you have to achieve the volume, but you'll have to prove that you're getting good outcomes and getting good quality. But this is just a start at that kind of discussion. By the way, as I'm saying these things, one of the things I should have mentioned you might want to have in the back of your mind is, of all these things I'm talking about, just think about the extent to which information would be helpful in doing these things. And certainly in compensation methods, I don't know how you do it without good information. On the population forces, the obvious aging population, greater chronic illness, which of course is caused to some extent by the aging population, but also by newer drugs and approaches that allow people to live for longer periods of time in a chronic state. So, for example, with diabetes or heart disease or cancer, which are all considered to be chronic illnesses today. Then there's the other population force, the shortage of skilled health personnel. And this, I'm not sure whether we have a shortage of skilled health personnel. I mean, it depends what you want to measure. In terms of the OECD countries, we're 26th out of 30 in terms of the number of physicians per thousand population. So you might say, compared to those 30 countries, we look like we don't have a lot of physicians. But we also say we don't have very many nurses. And when you compare ourselves to them, we actually are 9th out of 30 in terms of nurses. So compared to the rest of these countries, looks like we probably, relatively speaking, have a fair number of nurses. There's some really good modeling work that's being done on health human resources, which again requires data. Linda Lee O'Brien-Pallas does a lot of work on the nursing side, and I know ISIS, and actually Josh Tuppers, who is now the ADM of Health Human Resources in this province, is doing a lot of work on the physician human resource side to try and understand what the needs will be out into the future, and therefore what's the gap going to be between how many we are producing and therefore how are we going to fill those spots. But it's very interesting modeling, and I've been involved recently with the nursing guarantee for new graduates, guaranteed jobs for nursing graduates, and as part of that task force, which I chaired, we did a lot of modeling using the Linda Lee O'Brien's tools to really determine what the gap was going to be from a health human resource perspective. Delivery forces. Consumer expectations. Consumers want speed, they want close to home, and they want quality. And speed, I want that access now, fair enough. Close to home and quality often conflict with each other, which is a real challenge. And most of the public believe that they'll get quality just by going to the local hospital. But the reality is there are certainly things that shouldn't be provided at the local hospital. So we need to understand what are those things that can be provided close to home and what can't, because it's a trade-off between close to home and practice. Practice makes perfect. But again, there's been a lot of discussion in the media only recently that you don't have a lot of information as to even know where to go to get quality. You can't go into websites of most hospitals or health regions and see what the quality of care is that they provide. And you certainly can't get it at the doctor-specific level. Now, arguments can be made as to what level of detail you actually provide this information, but it should be provided at some level. You can go, by the way, into the Cardiac Network site and see which of the hospitals have the highest mortality rates, risk-adjusted mortality rates for bypass surgery. So if you're planning on having a bypass surgery, that is one place you can go to get that information. But the question is raised, why just for bypass surgery? The information just isn't readily available. And yet, consumers want high quality. They just have no information to judge whether they're getting high quality. Changes in drug care is a delivery change, much greater use, as I pointed out before, of use of drugs, and the drugs are very expensive, the newer drugs, and the issue of can we afford them. And changes in diagnostic imaging is another huge change in the healthcare system. And now not just having the images to make the decisions about therapy, but actually having the imaging and the therapy done at exactly the same time. So it's real-time imaging to decide where you're going to do your neurosurgery, where you're going to do the cut, for example. Some other delivery forces. There's, I'm sure some of you would have read the Commonwealth Fund study about IT and a number of other things related to primary care, which ranked Canada, of the, I think, 6 or 7 countries that they looked at, we were pretty much at the bottom. The only one that was close to us in terms of not looking good is the United States. So, you know, people always say we don't want to have an American system. Well, I would agree with that. But there are other systems that might be worth emulating short of the United States. So in terms of IT, this study found that in Canada, 23% of primary care physicians have electronic medical records in their offices. 23%, which most people who work in the field believe is too high a number, so we're not sure how they did their survey. But and 11% electronically prescribed. That's what the study showed. Whereas in Australia, Germany, Netherlands, New Zealand, UK, I averaged their numbers across those countries. It averaged 80% with electronic medical records and 72% electronically prescribed. That's quite a difference in terms of the state of our healthcare system and what goes on in a doctor's office. The image to me of going to a doctor's office, close your eyes and think of the first thing you see when you walk into a doctor's office. Paper charts, right? A whole wall of paper charts. You don't see computers, you see paper charts. And certainly when you go in your doctor's office, usually you see a lot of paper on their desk. It's not, they're not usually standing with their, or sitting with their computer keying in information as you speak, or electronically submitting their prescription. Now, some provinces are farther along in this than others, and that may well be why we think the 23% looks too high, because, you know, it's, we know what we know from where we live, but that's what the numbers are. So there is the willingness and ability to adopt new technologies is quite uneven. And this is true both at the provincial level. Some provinces have embraced the use of technology much more than others. Some provinces have come out and said information systems is a priority for our province. We're health information systems. And Ralph Klein said that when he was the premier. Most recently, it's been stated as a big priority in British Columbia, where I am. And British Columbia is actually pretty far along in a number of areas. You know, they've had all drugs, all people information system for 10 years. And for labs, they had what was called PathNet. I think they changed the name, where the private sector labs got together, and they tell me that 5,000 out of 7,500 physicians in British Columbia have access to PathNet, so they can see what test results on any lab tests that were done in the private sector, which is about 70% of their lab tests in the community. They can get immediate access to the results through the web. Very easy to sign up. We don't have that. Our primary care docs in this province can't get access to that, and we don't have all drugs, all people. Now we finally have access to ODB for at least for emergency departments. But so there's wide variation in terms of provinces' interest in getting on board with this, but also with practitioners. I mean, you'll see some practitioners who have electronic medical records in their office, and they're just looking for ways to link. And you'll see others that say, I sure hope I don't have to do this before I retire. So it's tough, you know. However, I learned, you know, in my work with teaching hospitals, where doctors tend to have their offices on site. If you want doctors to use this stuff in their offices, you have to make sure that they don't have to pay for it. That the technology is paid for, that their staff training is paid for, that the backup of their staff while they're being trained is paid for, and that there's ongoing coverage of any costs of upgrading the technology. And I'm not saying that to be critical. but that's just the way it is. And so in a way it's easy in a teaching hospital because we all know they get a lot of money, and so they just do that. That's what they do. They spend the money on that. But in the community, who's going to spend the money in the community, in the doctor's office practice, unless it's the government? And in Ontario, some doctors do through the money that was given to the OMA a number of years ago, but many don't. In fact, the majority don't. Just some metrics, just to give you an idea of how many transactions there are in a given day. This is data taken from CIHI 2002-2003 for Ontario, and they said in an average day in Ontario, 137,000 GP visits, 54,000 specialist visits, 41,000 medical images, 12,000 ER visits, and 3,000 hospital discharges. So a lot of activities going on. There could be a lot of other metrics, but so when we're thinking about information and information systems, we've got to see how big this system is in terms of the amount of information you'd have to collect to make it useful. Okay, so just wanted to say a couple of stories here, and just think about this in the context of informatics. A senior enters an emergency ward confused and disoriented and not knowing which drugs they are on, which is a pretty common phenomenon. And in some provinces, even today, the emergency docs have no idea what drugs those patients are on. So they have to guess, essentially. Hopefully the family's there, or if there were lab results. As I said, in some provinces, including our own, they wouldn't know what community lab results there were, recent lab results for that patient. So just think about how the electronic health record, the access to the images, the drugs, the lab tests, consults, all of these things, how useful they would be. A child in a small town falls from her bike, banging her head on the pavement. In some places we have CT scanning machines, which would be useful in a particular situation like this, but some of the time we don't have radiologists, right? Because we don't have enough radiologists to cover 24/7. So, with PACS technology, it really doesn't matter whether we have radiologists in that town. We can just get the thing read. In fact, in what year would that be? 13. Just trying to think how old my daughter is. So it'd be 13 years ago. So that'd be 1994. We were skiing in Vermont, and my daughter injured herself, and we had to take her into a hospital that had 50 beds. It was not a big hospital, but they had a CT scanning machine and no radiologist, because the radiologist lived somewhere else, and they read the images from home in 1994 in a 50-bed hospital in rural Vermont. For anyone who's been to Vermont, that is all there is in Vermont is rural. Like there are no cities. But it's 1994. I mean, we're just starting to catch up to this in this country, but so this particular example could have occurred back then in that particular state. A middle-aged patient with chronic diabetes needs to coordinate the findings, advice, and care of various specialists. I know we have the ability, or now we're forming the ability here in this town to have patient portals so the patient can try and keep hold of this information themselves. But for chronic disease, the fact that people's information is scattered among various specialists, so specialists can't even look at each other's information in a very easy way, has been a huge challenge. So, these three stories are just common everyday stories of what goes on in the healthcare system. And you could pick up many more. I wanted to just talk about what some others think are really essential in improving the healthcare system. So this is a Healthcare Renewal in Canada document which came out in 2006 from the Health Council of Canada. And they said there's 3 different areas that need to be addressed. It's a fairly comprehensive report. It's probably worth a read if you've never read it. The Health Council of Canada hasn't really got an awful lot of attention. It was put in place by a Liberal government, and we no longer have a Liberal government. And of course, then there are also 2 provinces that have refused to participate in it, Alberta and Quebec. So it's not getting probably the traction you would like it to get. But anyways, they said improve access to needed health care, improve quality of care, and improve population. So I'll just go through a little bit more detail what they said was important. And again, think in the back of your mind as I'm saying this how information is helpful. Interprofessional primary health care, which everyone thinks would be a good idea, so doctors, nurses, social workers, nutritionists working together in primary care. Education of more team-oriented healthcare workers. As you probably know, we're at a university now. Hopefully, as the University of Waterloo gets more and more into training healthcare workers, they'll try and do it in an interprofessional way, because that's not been the history of health provider education. They're only taught about their own discipline. In fact, they don't even know about the other disciplines, what they do. And so when they get out there, it's very hard to get them to be very team-oriented. Anyways, that's a sort of prerequisite for the interprofessional care. Broaden standards of practice, which gets at the same issue of all the different disciplines being able to do more of each other's work. And home care for chronic care. And what that means is the focus in most places in Canada has been to fund, government wants to fund home care to get people out of hospitals. So they call that acute home care. But then they don't want to fund home care to take people from the community and keep them out of hospitals or keep them out of nursing homes, which is probably even worse because it's so expensive once people get into nursing homes. So that's what they were suggesting would be useful. I don't have time to go into all my views on all these things, but I just want to go down the list. Still on the improved access, wait list management systems, standardized public drug coverage. There's the concern that every province has different drugs that they cover. BC is one of the worst if you're a senior. Ontario has a pretty good range of drugs that are covered. Better drug prescribing tools. The issue here being that how do doctors make decisions about which drugs they're going to prescribe, and obviously if you had electronic prescribing, it would make it easier to give them the evidence back, but prescribing tends to be done by writing it on a little piece of paper, scrawling it and then sending it in. You know, in Alberta, where they brought in their pharma system, they could put it in electronically, but they also, I'm told, had to submit it by paper because they didn't have the legislative framework to allow electronic to be good enough. And then the doctors didn't want to use the system. I wonder why, when they had to do both. Banning all direct-to-consumer prescription drug advertising. I think this is the concern there, is that the leakage of U.S. television over the Canadian border. They didn't like the idea that we could see drug advertisements across the border. Oh, there was one other thing I wanted to say about it was another example out of the Commonwealth Fund, and this had to do with drug prescribing tools, and it is that this was statistics on MDs receiving alerts regarding the problems with doses or interactions. So the doctor writes a prescription, and do they get an alert that maybe they put in the wrong dose or there's an interaction with another drug? In Canada, this was a survey of doctors. 41% said they do get those alerts, 10% via computer. So 10% of doctors said they're getting alerts via computer. So again, it probably depends on what province you're in, whether that's whether you're getting these alerts. But on 41%, so you got alerts, I guess, in some sort of phone call or whatever way. Now, if you go to Australia, Germany, Netherlands, UK, and New Zealand, and I averaged it, 90% of doctors say they get alerts about the doses, or wrong doses, or interaction, and 78% say they get it by computer. 78% versus 10% in our country. And I remember, now those statistics about how many people die in hospitals were the 23,000 a year. That was in hospitals. Here we're talking about in the community. So it's a different issue. But you can imagine the number of drug errors and drug interaction problems made in the community that, I don't think anybody's done a study on that one, not one that I've seen anyways. But when you look at those statistics, the difference between our country in terms of primary care and the enabling of drug prescribing and in these other countries is just staggering. Okay, so quality of care. Strengthen efforts, we're still back to Health Council of Canada. Strengthen efforts to reduce preventable harm, which was the issue of killing people in hospitals. No-fault compensation for victims, which the reason they want no-fault compensation for victims was to make it so that the providers are more likely to be willing to talk about mistakes that they make because they don't have to fear litigation against them. electronic systems for prescribing, they recommended, public reporting on costs and outcomes, and quality improvement training of healthcare providers. They also, on the improved population health theme, focus on healthy living, programs to prevent chronic diseases, information tools for management of patients with chronic diseases, data linking health outcomes with social and economic factors, and programs to reduce health inequalities. Different parts of the country have different levels of health. Richmond, I think, is the healthiest region in Canada, just where the airport is in Vancouver. I don't know if there's any link there. And in Ontario, I think Sudbury is one of the unhealthiest places to live. If you look at the work that CIHI puts out reports in terms of health status of the population. So there's major health differences. And you know, Sudbury has a very good hospital, right? They have very high tertiary hospital. So it's not the hospital that's caused, well, we hope, that isn't causing the health problems in Sudbury. So, you know, it's not just about health services, it's about population health, which is what they're saying. Okay, so those are the things they recommended. Back in the 1990s, there's a Professor Shortell, who's now the Dean of Public Health at Berkeley, but he came up to Ontario particularly and gave a lot of presentations on integrated health systems, ideal health systems. This is what Ontario was talking about, regionalization back in the 90s. And nobody seemed to care. But he would come up, and I think Peggy Leet, who I'll have another slide from her, but Peggy brought him up because they worked together as academics. And these are the things that Shortell said. Now, I love this list. I've used this slide on so many presentations I've given over the years, but I think about it, probably since 1993 actually, but I think about it from the perspective of, just think about information when you read down this list. Focus on meeting community needs. Presumably you need to be able to measure them. Matches capacity to needs. You need to be able to measure both of them. Integrates care across the continuum. This is the electronic health records. I mean, how else do you integrate it without being able to share information? Information systems that link consumers and providers so that you know, this is 1993. I don't know, I'd have to go back and read his book as to what he had in mind. You know, right now, a lot of providers, I know a lot of providers at UHM would tell me they receive lots of email from their patients, so they communicate directly with their patients. Now, I guess the younger patients, it would be text messaging or something, but they are linked to them on a regular basis to communicate. But he was suggesting that link between the consumers and providers back in 1993 provides performance information and aligned through financial incentives and structures. So those are the key things that Shortell was recommending would really make a difference to the healthcare system. And the alignment piece, well, the performance information I think goes sort of self-explanatory. The alignment piece, again, is one of the challenges that I mentioned before is often we don't have incentives in the system. So let's take primary care. It's my favorite. The old primary care thing was do as much volume. If you're a doctor, do as much volume as you can because you don't get paid much for each piece of work. So you have to really churn through it to make a half-decent living. Now the government, with the newer models of funding, has put financial incentives in there. So if you hit certain screening targets, you can get some more money. If a whole variety of things, like smoking cessation, you can now bill for that. You never used to be able to. So they give them financial incentives to actually do certain things that will actually maybe keep people healthier or help in managing their chronic diseases. There's special incentives around, I think, now for people with diabetes. So this is the kind of thing I mean. But it's not only having the financial incentives, because I've learned from my career that financial incentives really work. They don't even need to be really very big. They just need to be there. But you also need them in alignment between the different parts of the system, because you don't want to be aligning one part of the system to go in one direction, another part to go in another. So Peggy Leet, who I mentioned before, Peggy used to be the head of the Health Admin program at U of T, and then now it's called HPME. She's now the chair of health policy at Chapel Hill in North Carolina. She left a few years ago to go down there. And she sort of built, I think, on the views that I just mentioned that Shortell had. And some of her things aren't quite as information focused, but just so that this didn't look totally contrived, I thought I would just show what she said. Physicians play a key leadership role. You can't really have a healthcare system that works without physicians being engaged in leadership positions because they determine so much what goes on in the healthcare system. They need to be integrated. Some of you may have read work that's been done by Shalom Globerman. He's written on this along with the fellow whose name's escaping me from Mintzberg from Montreal on the issue of physicians as outsiders in the healthcare system. We have insiders and outsiders, and the docs are outsiders. They sort of work for themselves. They don't work within the system. And so somehow you got to get them into the system, and having them take key leadership roles is one of the ways of doing that. Organization structures that promote coordination. You know, we have LINs now, and one of the reasons for having the LINs was to have a structure that promoted people working together. And of course the LINs have funding authority, which is back to the financial incentive piece. District health councils also could do planning, but they didn't have funding authority, so therefore they couldn't provide the financial incentives to get people to work together. Primary care economically integrated, the same concept that I was talking about before. Rather than having these docs out there doing whatever they feel like, have the incentives that link them to the rest of the system. Practice sites provide geographic coverage, so it's clear who they're serving. And in this case, the LINs, which isn't really a practice site, but an organization structure, they have a defined population that they're responsible for. And the system appropriately sized, which gets to the issue, what's the needs or demand out there, and what's the various capacities, and how do you get the appropriate balance of services to meet the needs so that you have good flow of patients through the system, and also that you don't have bottlenecks in the system because, for example, we always talk about alternative level of care patients because they're blocked in the hospital because we don't have the right number of assisted living spots or long-term care spots or chronic home care spots because or acute home care spots for that matter. And physicians are organized rather than working by themselves. So we need 24/7 coverage of every discipline. So we have to make sure they're organized across the geography to make sure that somebody is on call when another physician needs access to them or a patient needs access to them. So these are the kind of things that Peggy was suggesting if you really want to have a successful system. So I sort of sum these up, and based on my own experience, but also some of this stuff, and I had others, but we don't have time. Focus on healthy living is a key direction that we need to go and that we're trying to go on. Greater use of evidence in terms of, this sort of gets to the cost effectiveness piece. We have to find out whether things actually work and can we afford them. The cost per quality life years saved. Are we willing to spend more than $50,000 a year to keep a person alive with a high quality life? We need sort of public debate on this. How much are we willing to spend as a society? And after that, if it's going to cost more than that, are we willing to give them the choice that somehow they come up with the money and pay for it themselves, so that if the state isn't willing to pay for it, then maybe a charitable organization could support them. In some cases, I don't know if you know, some of the drug companies provide compassionate coverage. So it's don't think I'm totally hard-hearted person here, but it's that kind of discussion. Drive to increase service cost effectiveness, which sort of is tied into the use of evidence, but really trying to focus on how do we keep the cost of health care from growing at a rate that becomes a higher and higher percentage of our gross domestic product. I mean, at some point, it's too much, right? It can't keep growing faster than the economy grows. I mean, it's 10.4%. Well, I guess we can handle that, but what about when it's 20%, you know? And I mean, the United States is still going up, and I guess they're just lucky in a way that they're a rich country. But as you know, in the United States, there's a lot of people that don't have much in the way of health care, so that's not an ideal thing. So anyways, this increasing service cost effectiveness, improving productivity, spending money on things that we know that work, and try to get good systems productivity as well, not just micro productivity, but macro productivity across the whole system. desire to address the consistency of access and quality. People are unhappy with the inconsistencies in access. If I live in Wawa, I want to be able to get access to health care, and the same as if I live at Bloor and Yonge Street. And of course, it's harder to give me access to care, but somehow you have to find a way to get me to have access to care because, I'm a taxpayer. I pay taxes just like anybody else. I may not be able to get it in Wawa, but I should be able to get it somewhere, and presumably you should help me get it. And why should it just be cancer, heart, cataracts, hips and knees, etc.? What if I'm not likely to need a hysterectomy, but what if I did need a hysterectomy? Why should I have to wait for a year to get a hysterectomy? Like, why is that less important than a hip or a knee? Particularly given with knees that 50% of the cases is caused by obesity. Of course, now I see in the newspapers we're paying for the procedures for obese people to try and help them reduce weight. So, but even there, I see the wait time for those obesity operations, something like 3, 4, 5 years. And so some people are going to the States because they want choice, because they don't want to wait 3, 4, 5 years. Plus, they know that the implications of living with that obesity, that morbid obesity for 5 years, may kill them. So so that's why they want choice. They're not willing to wait. But it's not one of the 5 areas that the federal government is trying to get the provinces to come to grips with on a wait time strategy perspective. Greater use of financial incentives and initiatives to achieve integration of care. So what I was going to do, and before I open this up, is just say a couple of words about how informatics tie into each of these directions, which I sort of figured was what I was here for. So a lot of this discussion was just preamble, these last few slides. So focus on healthy living. I was thinking of 3 different possible areas here where informatics have a key role to play. Patient education, for example, certified sites. I know if you go into the UHN website, you can actually do a search on sites that they've certified, and I'm sure a lot of other hospitals have done that as well, to identify for your particular disease information you could sort of count on to help you understand what's appropriate. Patient portal. We're leaders here at Grand River in terms of patient portal. I'm on the board of Canada Health Infoway. Canada Health Infoway is funding Grand River in its development of patient portals. This idea where patients can go in and keep their own information and have it in an easily accessible form is a huge advantage from a healthy living perspective, where I can record information about myself and take control of my own health care. Diabetes, hypertension, et cetera, and I can also link it presumably to the patient education sites and see how I'm doing. Something like diabetes, for example, the best practice guidelines for diabetes for doctors are something like this thick. I don't know if you've ever seen them. No wonder doctors don't want to use them. They're way too complicated. But if you have diabetes, which is the one everybody focuses on because it's such a big problem for us, huge advantage through patient portals and bringing together patient education. And then electronic medical records, more of a partners in care strategy where doctors and nurses and social workers can work together, and that's why I'm calling it electronic medical record, more of a team-based record to assist or support the person in terms of their healthy living. One of my favorite examples is, I'm sure we all go to now and again to have our teeth cleaned. And if you get your teeth cleaned once, then 6 months later or a year later, you'll get a call or a card. You get a card in the mail or a call from the dentist's office saying it's time to come in and have your teeth cleaned again. This is healthy living, right? Whereas if I'm a diabetic under the old fee-for-service system, I may never hear from my doctor that it's time to come and have anything checked, right? And we have diabetic clinics which operate out of hospitals that somehow aren't very connected to primary care physicians. So the sharing of information through an electronic medical record, this diabetic education kind of clinic, programs, is a key part of a healthy living strategy. Greater use of evidence. We put a lot of work at UHN into building evidence and into our order entry system. UHN has, I think, last I'm told, it's about 85% compliance of physicians in doing physician order entry for all kinds of orders, including drug orders. And so the move has been to build evidence into the computer system so that doctors can get immediate information, feedback as to whether they're doing the right thing. Are they ordering the right test? Are they giving the patient the right drug? So use of evidence embedded right in the order entry system. And we can see from the example I gave you about drug ordering, some provinces seem to be way ahead of us, or sorry, some countries seem to be way ahead of us in terms of providing that information back to doctors through computerization. But this is something we really need to work on here. And what I call the personalized medicine, this is sort of the linking of the research. So that order entry clinical decision support tends to work in its simplest form more at what's appropriate given that patient's diagnosis. But if you get into more personalized medicine, you can have a lot more information in there about the patient, like their genetic profile, their age, their history of other diseases, etc. And then the evidence that can come back to support the ordering physician or ordering nurse as we move more and more in, or ordering pharmacists. They're going to have ordering pharmacists now in Alberta. As we move more into that realm, that the evidence will be more customized to the individual based on the research and the profile of the individual. So very personalized medicine, which should be a lot more effective. In terms of, when you talk about dose management, the personalized medicine would have a huge benefit in the area of deciding what drug dosage people should receive. The drive to increase service cost effectiveness. As I mentioned, I think this needs to take place both at the macro level, macro system design, and the micro quality improvement. I'm a big believer in micro quality improvement, but I actually believe we can make much bigger changes in terms of sustainability of the system at the macro level. Because, you know, all organizations are working on micro quality improvement, some more than others, but there have been quality improvement teams around certainly since the 90s, so we've been working on this for at least 15 years. And as I said, some organizations do it better than others. But we need information to be able to do that. Macro system design, where we're looking at things like the location of care, what kind of provider should be providing the care, what technologies or procedures should we be using to deliver the care, which drugs should we be using, things like that. All of these sort of policy macro issues which really require good information on the needs, the demands, the capacities that exist throughout a range of geography and the health human resources that are available within that geographic region. The macro is where sort of the LIN comes into play and the information they need to do their work, and the micro is more at the level of the teams within an organization or across organizations. The desire to address consistency of access and quality. So regional service plans, which is a little bit of an overlap with what I just said, but we need to understand the characteristics of the population being served, the health status and the determinants of health of that population, the demand, the supply, the balance of resources, and as I mentioned earlier, this issue of closer to home versus practice makes perfect. Where should you be offering the service so that people can get access to it, but not in a way that actually diminishes the outcomes that they're likely to be able to achieve. And on the performance measurement side, this is an area where, you know, Ontario has done some reasonable work with hospital report cards, but we still have a long way to go because a lot of the data that's in the hospital report cards is pretty minimal, and trying to have good public reporting is essential if we're going to have a system that achieves consistency of access and quality. The public needs to know how the access and the quality in a particular place where they're receiving care matches up with not only what they could receive 30 miles down the road, but what are the benchmarks? We're talking a lot in emergency services about the percentage of people that leave without being seen. And there's literature that would suggest you should try and get that below 3%. And so if you're operating above 3%, you've got an issue. You've got an issue from an access perspective, and you've got an issue from a quality perspective, because people are leaving who maybe shouldn't be leaving, because maybe they're really sick. And they're only leaving because they don't want to wait for a long time. But that's just an example. The other thing about performance measurement, and this is one of the things that for people here who have worked in manufacturing, people who work in manufacturing, and I know there's a fair bit of manufacturing that takes place around this part of the province, the people who run the plants, the plant managers, they'll receive reports daily about what's happening in terms of performance in the plant. They'll receive income statements, balance sheets. They'll receive all sorts of performance information. In the healthcare field, we receive information once a month if we're lucky, and often that information is 3 to 6 months old. I was on the board of CIHI for a long time, and it was a bit of a dark humor, I suppose. We used to even kid ourselves about how we produced data often that was 2 to 3 years old, comparative data from across this country, 2 to 3 years old. So my view of that situation as a CEO was, so long as I changed jobs every 2 years, the data would never catch up to me. It worked, right? Yeah, exactly. Exactly. Greater use of financial incentives. I've said how important I think this is. So the global funding or the AFP kind of funding, volume-based funding, specific incentives related to productivity or quality. Probably one of the best funding mechanisms for doctors in the province at the moment is for radiation oncologists. They have sort of a base funding, and then they have volume-based funding on top of it. And so it encourages them to be productive, because let's say if you just gave them a salary, do you think they would see as many patients a day? I really doubt it. Now, the medical oncologists, on the other hand, they just receive a lump sum. They're not paid on a volume basis. And it's built into their agreement that if volumes do go up beyond a certain amount, they can ask to have more oncologists join their group. But there's no incentive for them to be more productive, or to look for ways to use other staff, to offload some of their work so that they can maybe oversee more, but spend less time with each patient. And there's a shortage of these people, so you'd like them to be as productive as possible. And there's a growing demand for systemic therapy. But their AFP was designed that way. Why was one designed one way and one designed the other way? God only knows. But I'll tell you, the discussions that are going around AFPs in many places in Canada seem to be more globally focused rather than incentive focused, and that worries me. I think we're missing a big opportunity, because you only sort of get one shot at this. Because right now, the reason why would a doctor be interested in getting an AFP in the first place? It's to have some assurance of how much money they're going to make, and particularly with academics, because they don't get paid to do teaching, they don't get really paid to do research. It's nice to package it all together and in a lump sum. But what a great opportunity if you can deal with the incentives for productivity, but even better for quality and outcomes as part of the design of the funding mechanism. So the provider, the funding models that we use for the caregiver organizations, what I mean by that is the hospitals or the long-term care facilities. How do we fund them to give them the right incentives? And how do we fund the providers, meaning the doctors, the nurses, et cetera, the home care workers, so that they have the appropriate incentives? And this is something where I think informatics and the information can play a big role. There are very few hospitals in Ontario that have patient costing systems. So when they come up with the funding, the amount they pay per a particular procedure, they have to rely on very few hospitals. Most hospitals wouldn't know whether they're actually making money or losing money. If they're given $5,000 to do a knee replacement, Do they make money doing that knee replacement, or do they lose money doing the knee replacement? Most hospitals wouldn't be able to tell you the answer to that because they don't have a costing system. Initiatives to achieve the integration of care, and this is my last slide. And so there's other things you can do to achieve integration of care. I'm not suggesting it's the only thing, but this may not be sufficient to have integration of care, but it's certainly necessary. How do you have integration of care without electronic health records? We're talking electronic health care records. I'm talking about integration across the continuum, so you don't have the situation where the patient comes into the emergency department and nobody knows what drugs they're on, what lab tests they're on, or you don't have the situation where a nursing home calls 911 and has a patient sent to the hospital and nobody knows in the hospital because no records came across with the patient. Or the situation, I'll pick on hospitals now, where they discharge patients and they maybe get a discharge summary to the family physician, maybe. And if they do, it might be a month, 2 months before the family physician actually gets that information. How do you achieve integration of care when you can't provide that information back and forth in a reasonably a short time frame? And then the electronic medical records, we're talking about integration of care here among providers, moving more of an interprofessional care approach, or even just more than one doctor, because nobody works 24/7, but we want patients to be able to receive care, access to care 24/7. So 2 doctors taking care of the same patient would want to look at and be able to get access to the chart, and paper charts are a very cumbersome way, particularly if the doctors are in 2 physically different locations. And then, of course, having doctors and nurses and social workers, et cetera, working together in the same office and being able to share the record as an integration piece as well. So there you go. I mean, I think it's just sort of blatant that if you want to have an ideal system, as defined by all these other much smarter people than me, but I sort of try to summarize it at the end as to what are some of the key things to have a really good system. Every single one of them just shouts out at you information, information, information. And yet, 33 years after Mark Lalonde, we're still futzing about here trying to figure out how in the world are we going to get our electronic health records and electronic medical records in place. So hopefully over the next 33 years we'll do much better. I'm going to stop here and I'll take any questions. Thank you.
So we'll open the questions to the audience and to the web, the video conference people. And so wait until we get the mic to you. Dominic and I will run around and get the mic to you. So just remember to hold the mic up to you right close, okay? So,
I had the pleasure in 1997 of being in a hospital in Australia and went into the intensive care unit. And lo and behold, there were 3 physicians sitting in an amphitheater such as this with 3 very large screens in front of them. And one of them had the electronic patient record on it. The other had a consult from a physician in a different country. And the 3rd screen had real-time telemonitoring of the patient who was in the bed, who was in front of them. And I was quite shocked because I came from Canada going into this intensive care unit and thought, oh my God, this is pretty exciting. And all their patients were hooked up, and their central nursing station was really just a bank of monitors. There was no papers, no files, no nothing. Everything was electronic. So it seems to me that our problem here is not about technology, nor is it about technology adaptation. It seems to be about investment and people's willingness to change and setting priorities on informatics. How do you think we're going to get there?
I think it is a lot about setting priorities. There are some organizations in this country that have decided to set it as a priority, set electronic health records or electronic medical records as a priority. If you go up to the group health people in Sault Ste. Marie, they have electronic medical records shared among many people. They've had it for quite a few years. The Hospital for Sick Children has great electronic health records system. Baycrest has a really good system. So you can look around at individual institutions, but they've really invested, which gets to your point. At UHN spends over 5% of its operating budget. Let's say 4.5% of its operating budget on information systems. And the way we used to develop our budget when I was there was we said we're going to spend 4.5% of our operating budget on information systems, regardless of what our operating budget is. We just said that was the principle. Now, we expected that something would come out the other end, so we had other ways of looking at what we were getting for our 4.5%. But there was never any question as to whether we would reduce our spending on information systems. And as I said before, some provinces, like Alberta, I guess because Ralph Klein said it was a priority, they really forged ahead, and they did invest in it. And you take the Capital Health region in Edmonton, which may be the region that's the farthest advanced of any region in Canada in terms of electronic health records, where last I heard about 1,500 physicians in the community are tied into drug information, lab information, and medical imaging, and also linked to the regional information system. So they get a comprehensive set of information on their patients. But that's because these jurisdictions decided it was a priority. They have high expectations for what comes out the other end, but they said it was a priority. So I agree. It's not a technology issue. Technology is getting better and better. We had electronic health records to some extent at Sick Kids when I was there in the early 70s. So there's nothing new about this stuff. It's just a question of whether the organization wants to put the focus on it, give it the priority, and invest in it to make it happen. And as far as the individual practitioners and will they get on board, if you give them enough support in terms of making sure you listen to them, involve them in designing how the system is going to work, and if you make sure that you do it in a way that doesn't slow them down too much, because they want to provide care. They don't want to spend all their time, having system crashes. Then they'll get on board. I've seen that. They got on board at Sunnybrook when I was there. They're getting on board out in BC, where I was. So, and certainly at UHN. So I think it's all about focus and investment and priority.
Tom, in my dealing with many doctors to try to get a diabetes system going over the internet, the biggest difficulty I had was getting them to use a computer. It's going to cost me too much money. I don't want to do it. So there's no incentive from the government to the doctor, and to the doctor, money is king. So if you give him some kind of financial incentive to put that computer in and help him get it set up, perhaps that will make him use it, because he will get more income by using the computer, because the technology there is very simple, but to get them to do it seems to be impossible unless there's a little more money in their pocket.
Well, Jim McLean, who was head of the Family Health Team Initiative, I think their practice is just down the road here somewhere now. I'm trying to think of where they moved to. He and his wife, Heather, she's a family physician as well. But they had practice in Markham, and now they're somewhere in southwestern Ontario. And they're telling me they have electronic medical records in the office here. And both of them say that, they may have been pioneers in this. I know Heather said to me she was a little nervous about getting into it, but once she got involved in it, she would never go back. Now, that was a practice where they just decided to do it on their own, I think, without any financial incentive. But I think most practices, people don't want it to come out of their pocket. And these are practices where the costs are quite high just to run a practice. And if you have to also add on to that the cost of putting the computers in, et cetera, it's quite expensive. And do you see the benefit coming out the other end? They're nervous about that. So, and of course, when you first put in these systems, it's disruptive. It takes a while till people get used to it. So I think somebody needs to get people over the hurdle. The other issue is they might have an electronic medical record and be able to run their office better, but what information can they actually access with their electronic record? If there's no provincial data set for drugs, or no provincial data set for medical images, or no provincial data set for lab tests, you've just lost most of the benefit that the family physician would get. Or if it was unclear how they link to refer patients on to specialists, like, you have to give them applications that are going to be of value to them at the same time. So the business case is much better once all the functionality is there as well, which means it has to be addressed in a more systemic, at least regional basis, and ideally provincial basis.
Yeah, Tom, I couldn't be more supportive on the concept of interprofessional and informatics, and it's something that we're looking at as we're establishing a health sciences campus here and a new school of pharmacy and bringing the medical program. Let me be rather controversial here, if I can. There's a statement that people sometimes use about statistics, and it's something like this. He uses statistics as a drunkard uses a lamppost for support but not for illumination. And,
are you talking about me?
And I wonder a little bit whether all of these numbers that we use so easily about costs of things, whether they are supporting our internal beliefs but rather not particularly illuminating. I'm wondering if anybody has ever done an estimate on the wealth potential in healthcare. Because we always view it as cost, like, you know, in the area of drugs, for example, 18% of healthcare costs are attributed to drugs, for example. Well, yeah, it's an expenditure, but it's an expenditure only on one side of the equation. There are all kinds of other things. If you go down University Avenue, you look at the prosperity that's created by the whole healthcare system. It's phenomenal. Every FedEx truck that comes there, every tax dollar that gets spent and goes in the government coffers, etc. There is a wealth that's created by healthcare. And Tom, is anybody looking at the bigger equation so that we don't look at just some of these minuscule numbers that are statistics?
Mm-hmm. Yeah, I think there are people that do those kind of analyses. You know, one of the suggestions as to why we've had such a good automobile industry in Canada has been because of our public health care system, right, and the fact that it was low cost to employ, because there wasn't a high cost of health insurance, just because of the way the system was structured, with funded by a single payer. Certainly, the academic hospitals have done work on looking at the economic impact of the health research that they do. There's a lot of small studies that try to prove that investing in health or investing in health research actually help the country be more productive. And certainly, if you have a healthy workforce, because we have very high, you know, let's say absenteeism, disability rates, etc., which presumably could be aided by keeping people healthier, which would improve the productivity of the country. All these kind of analyses. I think it's tough, though, for government, because government looks at it in terms of mainly from the perspective of what percentage of the provincial budget they're going to have to spend on health care. And that number keeps going up. I just saw a straight line, or it was a straight line projection, which is always a bit dangerous, but it's done by the province of Alberta, which says that by the year 2020, they'll be spending 56% of their budget on health care. And right now they spend quite a low percentage, something only like 35%. So they're really worried about this. But that is the kind of thing that worries the politicians, because they don't want to raise taxes, because they think that could have a negative impact on the economy. And but no, you're right. I mean, it's a much more complex, from an economics perspective, it's a much more complex subject. I just think that often the way it gets discussed by governments in terms of budgets is a much simpler way. And as far as drugs are concerned, yes, I mean, who's to say that that's a bad thing that we've doubled the expenditure on drugs? I don't think it is necessarily a bad thing. If you look at the same time as to what are some of the drugs that have cost us so much, it's had a real impact on other costs within the healthcare system. It's reduced, you know, the amount we spend on doctors as a percentage has gone down a lot. The amount we spend on hospitals has gone down a lot. And with hospitals, it's because people are in a shorter length of time, and a lot of that's related to drugs that they're on that can keep them stabilized, et cetera. So it isn't necessarily a bad thing. But then you look at it from the other perspective, and when you have a new drug for cancer that costs $200,000 to keep people on average alive 8 more months, when you look at it at the, sort of that micro decision point basis, then government gets really nervous. They say, how in the world can we afford that? Because if there was only one of them, that wouldn't be a problem. But there's a whole bunch of them coming down a pipeline, and they're all similar in terms of how little they actually help and how much they cost. So these are the kinds of dialogues that go on.
On the appropriate role for government in the whole health IT thing, I'll leave aside some of the, I guess, more celebrated Canadian examples. I was reading today about the National Health Service program in the UK, where they've made an extraordinary investment in IT, but are also having extraordinary challenges getting adoption amongst the healthcare community, particularly physicians. And it seems to have a lot to do with the fact that it's centrally controlled, government-sponsored, government-run. Can you comment a little bit on that?
Yeah, I think I wrote something a number of years ago for as an editorial, the Coach magazine, Health Care Computing in Canada, whatever it's called now. And that article was about, or that editorial was about the issue of adoption and how if you really want to see adoption of computer systems, it has to be you have to design them more, you have to design them closer to a community of interest. They have to be designed by the people who are ultimately going to use them. Because if you don't, if they're designed too far away, there's no way they're ever going to look right to the people who you want to use them in the end. And so that's why the British approach, which is more of a national approach, is a huge challenge, because organizations that have systems already are being told you can't use those systems anymore. You have to sign on to the national system. In Canada, with Canada Health Infoway, they're trying to define standards, but nationally. But they're also trying to let the solutions, to some extent, be local. Although they're also looking at the potential for replication of code from one place to another. But nobody's requiring that everything be exactly the same. My answer to this, in a place the size of Prince Edward Island, you would presumably only have one system, right? 140,000, 135,000 people. But in a place the size of Ontario, I think systems should be designed a lot more along LIN lines, because I think that you've got a critical mass, which you would want. But I don't see why the systems would have to be the same in northwestern Ontario as they are in the city of Toronto, for example. And if you can sort of chunk it out and get people more involved locally in the design of the interfaces and the priorities for functionality and when things come on and what order they come on and how they're supported and bringing them on, I think that's going to lead to much greater likelihood of adoption than we would see in the British model. But I've heard the same thing. They're having a terrible time in England.
So I had a question about adoption as well. Like in the stuff that I'm used to in computer networking or IT systems, the way stuff seems to happen is there's like people who seem to get paid enough to sit around and just research the ideas and think about ways to do things and build stuff. And they're kind of, they're different than early adopters. They're maybe rooted in both camps, the technology and the application, but they seed the creation of the appropriate solutions such that then other people can get enough experience with it and start to adopt. And we seem to be trying to adopt the wholesale thing with no experimentation just by designing it right on the part of governments or LINs or some large group that's probably too large to really be able to do it, and there's no successive refinement. And I'm wondering if you see any ways, or if it would ring true, would resonate with your own experience, to somehow seed this system with people whose job it is to experiment with this stuff. I mean, given the savings we could get, we could certainly afford to do it.
Yeah, well, I think the important thing is that we agree on standards, because we're trying to have we're trying to integrate the system. Therefore, we need to be able to move information across the system because patients move across the system. So the standards are the important part. And I think that'll also make it easier to link software products together, best-of-breed solutions. But I would agree that experimenting locally makes an awful lot of sense because it's a way of getting buy-in and refining at the local level. So, you know, there shouldn't be a one-size-fits-all. However, if you look in Canada, in hospitals, what's the most successful hospital patient care information system? It's Meditech, which is a pretty structured, standardized application software product. But then there are other places that say it's too structured for us. We'd like to do something that's different, more creative maybe. And so they go other routes. But the fact, I guess, that they have the choice says something, right? Not everybody's being forced to take one solution or another solution. And I think it has to be a bit of a balance, I would agree. I think within a LHIN, though, particularly smaller LHINs, there would probably be some real advantage to some joint purchasing of common products. And I think it's probably a bit wasteful, particularly to have multiple solutions, particularly because the doctors may actually be working across multiple sites. And I know from my own experience that if you have doctors working across multiple sites and the system looks different at each site, it's very frustrating for them. So we have to think about who's actually going to use the system.
Well, thank you very much, Tom.
Thank you.
Great presentation.
Thank you. Oh, thank you.
Large gift as a token of our appreciation. And thank you all for coming today. I hope to see you all here next month, May 23rd, for our next presentation, and have a great rest of the day. Thank you very much.